the next topic for the discussion, connective tissue disorders. Right, the next topic for the discussion will be connective tissue disorders. So, in the connective tissue disorders, today I will try to cover this hepatology, then connective tissue disorders, plus or minus nephrology and endocrine. Plus or minus, it all depends upon the number of students who will be there online, because if more number of students are there, it will be encouraging for me. Definitely I'll be doing more systems. If number drops down drastically, right, I will not have any encouragement to continue the class. Okay, chalo. And it also depends on me how I am engaging you. That is also the the tagline mark. So what exactly is this? The patient is having enlarged spleen and the patient is having rheumatoid arthritis. This particular syndrome, it is Felty's syndrome. This syndrome is the Felty's syndrome. Now I have given you a clue. Very good. So the answer is neutropenia. The answer is neutropenia. What is this? It's a Felty's syndrome. So in Felty's syndrome, what is that? You will have rheumatoid arthritis, splenomegaly, and as well as neutropenia. Right? And when will this new Felty's syndrome develops in rheumatoid arthritis patient? Felty's syndrome occur in chronic patients of rheumatoid arthritis. Like basically after 10 to 15 years of onset of the rheumatoid arthritis, there can be development of this Felty's syndrome, right? And if the patient with rheumatoid arthritis is treated aggressively with DMARDs, the chances of developing Felty's syndrome will be very negligible. Okay, so are you all ready for the rheumatoid arthritis quick revision? Right, as already I have said you guys, those students who are joining new, the PDF of this particular topic is available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can download this PDF from this my Telegram channel. And if you're all liking my sessions, you can follow me on my Instagram, that is Rajesh Gubba, where you can have the clinical material every day related to general medicine. Right, now starting with the session. First and foremost, the definition is, what is this basically? It's a chronic inflammatory disease. And in this chronic inflammatory disease, the joints which are commonly affected is small joints are being affected. Small joints are affected, and that too symmetrical involvement. Symmetrical involvement. And it's an autoimmune condition, guys. So because it's an autoimmune condition, it is very common in women rather than men. What is the age group at which you see this rheumatoid arthritis? This is very common in the age of 4th to 5th decade. Very common in 4th to 5th decade. And in the pathogenesis, please remember, it is not just only the bone which gets affected in rheumatoid arthritis. It involves both the cartilage and as well as bone. So there is erosion of the bone and erosion of the cartilage. And the key symptoms in these patients will be morning stiffness. And this morning stiffness will be there for more than 1 hour. Whereas you take in osteoarthritis also, there will be morning stiffness, but this morning stiffness in osteoarthritis will be less than 1 hour. That is the important difference in the morning stiffness of rheumatoid arthritis and osteoarthritis. Okay. Now, what are the other features apart from morning stiffness within the small joints? So what are the joints which are affected in this? That is the PIP, MCP and MTP. What is that particular joint which is not affected? That is DIP is not affected. But in which conditions the DIP is involved in? DIP is involved in case of the osteoarthritis as well as the psoriatic arthritis. Osteoarthritis and psoriatic arthritis. Okay. Now, and in these individuals, as the time passes, in these individuals, as the time progresses, coming to the deformities. So now the deformities that you observe in these patients with the rheumatoid arthritis is, you have swan neck deformity and as well as the Bottom's deformity, right? These two are the important deformities. And another important deformity that you will have is the ulnar deviation, right? Ulnar deviation. And you also have the presence of the Z-shaped thumb. You will also have the presence of Z-shaped thumb. So these will be the deformities that you will have in patients with the rheumatoid arthritis. And in rheumatoid arthritis, do you have spine involvement? Yes, spine involvement also will be there. And that is mainly cervical spine, that is C1 and C2. And whenever there is spine involvement, there will be atlantoaxial dislocation resulting in quadriparesis. Okay. And what is the most common extra-articular manifestation? The most common extra-articular manifestation that will be subcutaneous nodules, and these subcutaneous nodules will be there over the extensor aspect of the forearm, and these subcutaneous nodules, they're painless. They're painless, and multiple systems are affected. Lung involvement can be there in the form of pleural effusion and interstitial lung disease, and the eye involvement can be there in the form of scleritis, and cardiac involvement can be there in the form of pericarditis. So please remember, in case of rheumatoid arthritis, it is not only articular, there will also be extra articular manifestation as well. Then how is that you will do workup in patients with the rheumatoid arthritis? So the workup is, you have one non-specific investigation. What is that non-specific investigation? RA factor. But this RA factor is positive in multiple conditions, not only in rheumatoid arthritis. Then what is the investigation of choice, which is like more specific? The more specific investigation will be the anti-CCP. Anti-CCP is the more specific investigation in case of the rheumatoid arthritis. Now, whenever you are treating these patients, what is that you should focus on? You should focus on reducing the inflammation and preventing the deformity. So in acute cases, you can give NSAIDs and as well as steroids, but as a part of the maintenance, the drugs that you should give is the DMARDs, disease-modifying anti-rheumatic drugs. And in this disease-modifying anti-rheumatic drugs, what is the drug of choice? The drug of choice will be methotrexate. Methotrexate is considered as the drug of choice, right? And these are non-biological DMARDs. These are non-biological DMARDs: methotrexate, sulfadiazine, leflunomide, and hydroxychloroquine. And what are the biological DMARDs? The biological DMARDs will be the TNF-alpha inhibitors, abatacept, rituximab, and Janus kinase inhibitors, that is tofacitinib, and then baricitinib. These two are Janus kinase inhibitors, right? And we were discussing about the complications, that is cardiovascular disease. If at all, if there is death in patients with rheumatoid arthritis, it is mainly because of the cardiovascular abnormality. It is mainly because of the cardiovascular abnormality. So this is about your rheumatoid arthritis. So quickly, what is the problem here? Chronic inflammatory disease, symmetrical polyarthritis, small joints are affected, more common in women, right? And there will be morning stiffness that will be there for more than 1 hour. Small joints which are affected is PIP, MCP, MTP. DIP is not affected. Cervical spine is involved. Atlantoaxial joint dislocation. Most common extra-articular manifestation will be subcutaneous nodules. The most specific investigation will be anti-CCP. Treatment should be the anti-inflammatory drug, and you need to prevent the deformities. You need to give DMARDs. And that particular DMARDs will be methotrexate is a drug of choice. And in refractory cases, you need to start the biological DMARDs. And the cause of death will be cardiovascular abnormality. Done. Your rheumatoid arthritis is over. Now, coming to the next topic, that is the ankylosing spondylitis. Okay, chalo. You please see this question and answer this. We have a 28-year-old man presents to the clinic with complaints of the low backache persisting for past 3 months. Which of the following statement regarding presentation of the back pain is appropriate? Low back pain persisting for past 3 months. Which of the following statement regarding the presentation of the back pain is appropriate? So low backache for 3 months, and that too in an age of 28 years. So definitely you need to think of the ankylosing spondylitis. So, right. So Anash has answered it correctly and Kashmiri has answered it correctly. That is, pain in neurogenic claudication, it worsens with standing. Pain in neurogenic claudication, it worsens with standing, and also it worsens with walking. Also it worsens with walking, right? And back pain in sciatica and disc prolapse is diurnal? No, it's a wrong statement. Back pain in sciatica, it increases with activities like bending, lifting, and as well as the prolonged sitting. Whereas pain in Buerger's disease, which is nothing but thromboangiitis obliterans, it typically worsens at night. So please remember, in case of the Buerger's, the pain will get increased on exposure to the cold temperature. It is not specifically noted to worsen at night. That is your Buerger's disease. Then you take the last option, that is pain relief is typically observed with use of gabapentin or pregabalin in case of the ankylosing spondylitis. It's a wrong statement. What we give in case of ankylosing spondylitis, it is indomethacin, not this pregabalin or gabapentin. So the correct answer here is second option, pain in neurogenic claudication worsens with standing. Okay, right. Now we will do the detailed discussion of the ankylosing spondylitis. Detailed discussion of the ankylosing spondylitis. Okay, right. What is this ankylosing spondylitis? Please remember, ankylosing spondylitis is also a chronic inflammatory disease. Which part of the body is affected in ankylosing spondylitis? That is, the axial skeleton is commonly affected, right? Where you have the abnormality within the spine and as well as the sacroiliac joints. These two are the common organs which are affected in case of the ankylosing spondylitis. Okay. Now, this ankylosing spondylitis, it is a part of the seronegative arthritis. Now, what are the other examples of seronegative arthritis? Please remember this mnemonic, that is PAIR. What is this pair? P stands for psoriatic arthritis. A stands for ankylosing spondylitis. I stands for inflammatory bowel disease. R stands for the reactive arthritis. Okay. Now, what are the associations? Please remember the association of the ankylosing spondylitis. It is with the HLA-B27. And what is the age of onset? Around the age of 40 years. And it is very common in adolescence or the early adulthood. What is the important symptom in patients with ankylosing spondylitis? That will be low back pain. Low back pain is a very important symptomatology. And this particular low back pain will be there for nearly around 3 months. Will be there for nearly around 3 months, right? And along with that, the other features that you will have is morning stiffness, reduced spine mobility. Why there is reduced spine mobility? Because there is fusion of the vertebra. That is the reason why you have reduced spine mobility. Now, what is the test that we do for assessing the spine mobility? The test that we do for assessing the spine mobility is the Schober's test. And the Schober's test will tell you that there is restricted spine mobility. And not only that, in these individuals, there will be restricted chest expansion. And what is the most common extra-articular manifestation? The most common extra-articular manifestation in ankylosing spondylitis will be anterior uveitis. And apart from anterior uveitis, the other features that you will have is enthesitis. And in the heart, there will be aortic regurgitation or aortic insufficiency. And these patients can also develop the complete heart block. And that is because of the AV nodal block. That is an ankylosing spondylitis, right? And what will be the radiological features? Radiological features of ankylosing spondylitis has been asked multiple times. So when you do X-ray of the spine, you will have the bamboo spine. And there is pseudo widening of the joint spaces. Pseudo widening of the joint spaces. There will also be squaring of the vertebra. And whenever you do an MRI, MRI will show you that there is the bone marrow edema. MRI will show you that there is bone marrow edema. That will be the radiological finding in patients with the ankylosing spondylitis. And extra-articular manifestation, just now I have said you, anterior uveitis is the most common extra-articular manifestation, right? Then how is that the workup that you will do in patients with ankylosing spondylitis? As I have already said you, the HLA-B27 will be positive, right? And you have the characteristic X-ray and MRI finding. What is that X-ray finding? One is your bamboo spine, right? One is your bamboo spine, pseudo widening of the joint spaces, squaring of the vertebra, and MRI will be showing the bone marrow edema. MRI will be showing bone marrow edema. And what is the name of the diagnostic criteria? That is ankylosing spondylitis criteria, in which you should have HLA-B27 positive. Along with HLA-B27 positive, there should be imaging and as well as the clinical features of the spondyloarthritis. What is the imaging features? Same, bamboo spine, squaring of the vertebra, pseudo widening of the joint spaces, right? What is that you'll have in MRI? MRI will show you bone marrow edema. So that should be there on the imaging. What will be the clinical features? That will be low back pain. That will be low back pain. Okay. Then what is the drug of choice? Drug of choice will be indomethacin. That is a drug of choice, right? And whenever you're giving indomethacin, the individual should clinically improve. So what is that particular tool which will assess the disease activity? The tool which will assess the disease activity is the BASDI index. That will give you the important methodology of assessing the disease activity. Now, if you are giving indomethacin, but if your BASDI index is like score is more than 4, that will tell you that the disease is, the individual is having a poor disease control. Now, from the indomethacin, right, from indomethacin, you need to shift to the anti-TNF agents. From the indomethacin, you should give the biologicals. And this particular biologicals will be anti-TNF agents. These biologicals will be anti-TNF agents. Okay, next. What is the complications? The complications that you will have is the spinal fusion. I said you already, the vertebra will be fused. Cardiovascular abnormality can be there in the form of aortic regurgitation and complete heart block, and there will be reduced quality of life. There will be reduced quality of life. Okay, so this is about the ankylosing spondylitis. So to quickly summarize ankylosing spondylitis, chronic inflammatory disease, spine and sacroiliac joint is commonly affected, right? And seronegative arthritis, please remember the mnemonic pair. And your ankylosing spondylitis is also seronegative arthritis. That means RA factor will be negative. And the key association will be the HLA-B27, right? HLA-B27 will be positive. Age of onset, around 40 years. Key symptoms, inflammatory back pain, low back pain, and loss of spinal mobility. How will you test for reduced spinal mobility? Sjogren's test, right? Then radiology, X-ray will show you bamboo spine. MRI will show you bone marrow edema. And extra-articular manifestations, most common, anterior uveitis. Investigations, HLA-B27 being positive, right? And treatment, indomethacin is the drug of choice. In refractory cases, you need to give the anti-TNF agents. How will you test the refractoriness? Bajda index. Complications, complete heart block and aortic regurgitation. Done. This is about your ankylosing spondylitis. Right. So Reiter syndrome or the reactive arthritis. Right. Reiter syndrome or the reactive arthritis. So what exactly is the problem here? Reiter syndrome or reactive arthritis, it's also a seronegative arthritis. It is characterized by a triad. What is the triad? That is urethritis, arthritis, and as well as the conjunctivitis. Urethritis, arthritis, and conjunctivitis. Okay, these three are the triad. And in order to develop this Reiter's or reactive arthritis, there should be a background history. What should be that background history? The individual should be having either gastrointestinal or the individual should be having a genitourinary infection. Right. And what is this gastrointestinal infection caused by? Gastrointestinal infection is caused by Shigella, Salmonella, and Campylobacter. Genitourinary infection is caused by the Chlamydia trachomatis. And what is the most common organism that will be causing your Reiter's or reactive arthritis? That is Chlamydia trachomatis. Okay, that is the most common organism. Done. Then HLA, as already I have said you, it is the HLA-B27 that will be positive. HLA-B27 that will be positive, right? And okay, so in between the ads are the one which are little demotivating. Chalo, theek hai. Right. Then next is the epidemiology. So please remember, this is more common in men than compared to that of the women. So what is the important part of your arthritis? It is not polyarthritis, it is oligoarthritis. It is oligoarthritis, followed by that enthesitis, very important cutaneous manifestation. That will be keratoderma blennorrhagica. Right? Keratoderma blennorrhagica. What is keratoderma blennorrhagica? Keratoderma blennorrhagica is the presence of the keratotic vesicles, hyperkeratotic lesions over the palm and sole of the foot. That is called keratoderma blennorrhagica. So these are the key symptoms in case of the Reiter's or the reactive arthritis. So how will you diagnose Reiter's or reactive arthritis? You need to do the culture, right? You need to do culture from urethra, cervix, throat, and culture of the urine and as well as stool. HLA-B27 is the one which will be positive, right? And now, if you take the arthritis here, asymmetrical arthritis, whereas in rheumatoid arthritis, we have discussed symmetrical polyarthritis, whereas here asymmetrical oligoarthritis, that is very, very important. And what is the treatment that you will give for arthritis? That is NSAIDs has to be given. And it is secondary to infection, right? So you need to give the antibiotics. Okay, but antibiotics are effective only in acute infections, right? Antibiotics are effective only in acute infections. Okay. Then next followed by that, the DMARDs. And these DMARDs, that is your sulfasalazine or the methotrexate for NSAID resistant cases. That means if the patient is not responding to NSAID, then you need to give DMARDs like methotrexate or sulfadiazine. Okay. And in refractory cases, you need to give the rituximab, that is an anti-TNF agent. Right? Skin manifestations are asked as multiple choice questions. And what is that skin manifestation? That is keratoderma blennorrhagica. Keratoderma blennorrhagica. Okay. And this is the important points related to Reiter's or reactive arthritis. Sure. Right. एक मिनट में रिवाइज करता हूं मैं. So retards are reactive arthritis, triad, urethritis, arthritis, conjunctivitis. Background history: gastrointestinal, genitourinary infection. Gastrointestinal: Shigella, Salmonella, Campylobacter. Genitourinary: Chlamydia trachomatis. More common: Chlamydia trachomatis. HLA-B27 positive, right? And this arthritis is oligoarthritis, and that too asymmetrical oligoarthritis. Skin manifestation: keratoderma blennorrhagica. Diagnosis by culture and HLA-B27 positive. Then the treatment: NSAIDs and antibiotics should be given. Refractory cases: the sulfadiazine and methotrexate. And not responding, you can give anti-TNF, right? And prognosis: it usually resolves. Good prognosis. So that is about retards or reactive arthritis. Done. Which of the following statement about the specific autoantibody in SLE is incorrect? First of all, what is the most specific antibody about the specific autoantibodies in SLE is incorrect? Okay. So what is the first option? Anti-Smith antibody is highly specific for the SLE. That is correct. Okay. And anti-Rho antibody is associated with photosensitivity and complete heart block in fetus. Correct. Then anti-dsDNA, it correlates with the disease activity in SLE. Correct. Then anti-lupus anticoagulant decreases the risk of the nephritis in SLE. That is the incorrect statement. So please remember, this anti-lupus anticoagulant, it increases the risk of thrombotic events. Right? It increases the risk of the thrombotic events. Okay. Now, because it increases the risk of thrombotic events, the individual will have recurrent abortions, particularly in females. And it also increases the risk of nephritis. Right? It also increases the risk of nephritis in patients with the SLE. Okay. So this is about the serology. Serology is very important in SLE. Serology is important in two scenarios. Number one, hepatitis B. वो serology revise करके ही जाना, hepatitis B serology. Number two, SLE. SLE serology antibodies you should revise and go before the exams. I'll give you a table, right? So this table, so I'm repeating once again, this PDF is available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. You can join and download this PDF. Right. So the antibodies, anti-nuclear antibody, it is highly sensitive. Anti-Smith, more specific for SLE. Anti-dsDNA, will correlate with the disease activity. Anti-Rho antibody, which is responsible for the photosensitivity. And it will also cause the complete heart block. And the other condition where you will have anti-Rho, that is Sjogren syndrome. Anti-lupus anticoagulant, there is increased risk of nephritis and increased chance of abortion. Anti-histone antibody, drug-induced lupus, and prognosis is better. Next, anti-phospholipid antibody, these individuals, they are at increased risk of the abortions. Then anti-erythrocyte antibody, it is associated with the development of anemia and as well as the autoimmune hemolytic anemia. Anti-platelet antibody, this will be causing thrombocytopenia. Anti-neuronal antibody, this can cross the blood-brain barrier and this will cause the cerebral edema. That is anti-neuronal antibody, right? And this anti-glutamate antibody, it is also the one which is associated with the CNS manifestations. Anti-ribosomal P antibody associated with psychosis in SLE. Anti-ribosomal, that is anti-RNP, that is anti-ribonucleoprotein antibody, that is in MCTD, that is mixed connective tissue disease. And this MCTD is not related to your SLE. What is MCTD? In MCTD, not only SLE, multiple other connective tissue disorders will be there in case of MCTD, right? So this is about the serology or the antibodies in case of the SLE. Chalo. Right. Shuru karenge. We will start with the SLE discussion. So in the SLE, what exactly it is? It is an inflammatory autoimmune disorder where you have autoantibodies. These autoantibodies are formed against the nuclear and as well as cytoplasmic components. And within the various systems, what are actually accumulated is the immune complexes are accumulated. And these immune complexes, they will cause damage to the systems. That is the reason why it is considered as a type 3 hypersensitivity reaction. What is the most common symptomatology in these patients? most common symptomatology will be fatigue, malaise, fever, arthralgia. These will be the key symptoms, right? Then, what are the skin manifestations? Skin manifestations will be in the form of malar rash, where there is fixed erythema over the malar eminences and sun-exposed areas. There is also discoid rash, where you have erythematous circular raised patches with scaling. There is also photosensitivity, right, where you have rash triggered by sunlight exposure. And there is also the oral ulcers, and they are painless oral ulcers. And if you take the organ involvement, right, multiple systems are affected. Skin, joints, kidneys, heart, lung, CNS, blood, everything is affected. What is that kidney involvement? That kidney involvement will be in the form of lupus nephritis. And there are totally 6 classes of lupus nephritis. But among all these, which is the most severe form? The most severe form is class 6, which is nothing but diffuse lupus nephritis. What is the characteristic biopsy lesion in case of lupus nephritis? That is the wire loop lesions. What are the cardiac manifestations? Pancarditis, pericarditis, myocarditis, endocarditis will be there. But which is more common? Pericarditis is more common. What will be the endocardial involvement? That endocardial involvement is Liebman-Sachs endocarditis, right? Where there is valvular involvement. And these patients, they are at increased risk of atherosclerosis and vasculitis. Pulmonary manifestations, if you see, that will be in the form of the pleuritis. That will be the most common manifestation. And that can result in the development of the pleural effusion. And there will also be development of what is called the shrinking lung syndrome. What is this shrinking lung syndrome and why is this due to? This is due to antibody formation against the diaphragm. Right? Antibody formation against the diaphragm. And this antibody which is formed against the diaphragm will cause the diaphragmatic paralysis. And that will cause the shrinkage of the lung. That is called shrinking lung syndrome. But this is a rare manifestation. What will be the CNS manifestation? That will be in the form of the seizure, psychosis, and cognitive dysfunction, right? And the antibodies which are associated with the CNS abnormality, that is anti-RNP antibody and anti-neuronal antibody. And hematological, already I have discussed, that is autoimmune hemolytic anemia, thrombocytopenia will be there. And APLA syndrome, that is the hypercoagulable state. Immunological markers, already I have discussed, I am not repeating here. But very important thing, what I want to tell you is about the drug-induced lupus. What is the most common drug? The most common drug will be procainamide, which is class 1 anti-arrhythmic drug. What are the other drugs that will be causing drug-induced lupus? Hydralazine, which is an antihypertensive, which is an arteriolar vasodilator. Isoniazid, which is an anti-tubercular drug. And this drug-induced lupus will resolve by stopping the drug. What is the name of the criteria for the SLE? The name of the criteria will be the EULAR or the ACR criteria. What will be there in this EULAR or ACR criteria? There should be a combination of the clinical and the immunological finding. And that immunological finding includes ANA, anti-dsDNA, and specific organ involvement. What is the treatment in these patients? Common presentation will be in the form of arthralgia. So in mild cases, you can give NSAIDs and as well as hydroxychloroquine. But in moderate to severe cases, they will be requiring the immunosuppressive agents like glucocorticoids. And the other immunosuppressive agents which can be given is mycophenolate mofetil and as well as cyclophosphamide. And if at all, if there is cutaneous involvement, for that you need to give the hydroxychloroquine and you should avoid the sun exposure. And in refractory cases, corticosteroids have to be given. And if at all, if there is CNS involvement, you need to give antipsychotics and as well as steroids. And overall, what is the cause of death in these patients? Overall, the cause of death in these patients with the SLE will be infections, and that is because of neutropenia. And in early stages of SLE, the cause of death could be even due to renal failure. And in the later stages of the SLE, the cause of death can be even the thromboembolic events as well, right? And these patients, there is increased risk of premature atherosclerosis that will result in the coronary artery disease. So this is about your SLE. SLE is done in just 5 minutes. Okay. So now in 1 minute, I will revise. So it is an autoimmune condition, type 3 hypersensitivity reaction, right? Common manifestations will be like fatigue, malaise, fever, arthralgia, skin manifestation, malar rash, discoid rash, photosensitivity, and oral ulcers. Kidney involvement in the form of lupus nephritis, class 6, which is the most, class 4, which is like most severe form, wire loop lesions. Cardiac manifestations, pancarditis, most common is pericarditis. Pulmonary involvement, pleuritis, pleural effusion, rare manifestation will be shrinking lung. CNS manifestations, seizure psychosis. Hematological abnormality, autoimmune hemolytic anemia, neutropenia, and thrombocytopenia. Immunological markers, most sensitive, ANA, most specific, anti-Smith, the one which will tell you about the CVRT, anti-dsDNA. Drug-induced lupus, most common drug, procainamide, anti-histone antibody. Name of the criteria, EULAR or ACR criteria. Mild cases, NSAIDs and hydroxychloroquine. Moderate to severe cases, glucocorticoids. Cutaneous manifestations, hydroxychloroquine. Right? CNS, you need to give the antipsychotics. Overall cause of death, the infections. Okay. So this is about your SLE. SLE is over. Coming on to the next topic for the quick revision, that will be the Sjogren syndrome. That will be Sjogren syndrome. Basically, the entire clinical scenario which is being given, where there is dry eyes and dry mouth, and there is episodes of gritty sensation in her eyes, difficulty in swallowing. So, dry eyes and dry mouth. Suggestive of Sjogren's. What is the HLA association? So, the HLA association in case of the Sjogren's, it will be HLA DR3, DRW52. That is a HLA association in case of the Sjogren's. Okay. So now, in case of the Sjogren's, this is also an autoimmune condition. Right? So this is also a systemic autoimmune disorder. Where is the problem? Eyes and oral cavity. So dry eyes and as well as dry mouth. Dry eyes and dry mouth. Autoimmune condition. So it is common in women rather than men. What is the age group at which you see this commonly? 40 to 60 years of age. And because it's an autoimmune condition, the gland is infiltrated by the lymphocytes. And what is that lymphocytes? CD4 plus T lymphocytes, right? And that particular lymphocytes will produce the antibody that is anti-Rho and anti-La antibody. And this particular Sjogren's, it is of two forms, primary and secondary Sjogren's. Primary Sjogren's is that only Sjogren's, that is called Sika syndrome. Secondary Sjogren's is that along with Sjogren's, you have other associated autoimmune conditions like rheumatoid arthritis, SLE, scleroderma, and primary biliary cholangitis. This is what is nothing but your secondary Sjogren's. Then, what are the important symptomatologies that you will have in case of Sjogren's? That will be in the form of dry eyes and dry mouth, and parotid gland enlargement will be there in 50% of individuals due to infiltration of the lymphocytes. And there is also difficulty in swallowing the dry food, dental caries, and in females, they will have dry vagina. And that is due to damage to, or that is due to destruction of the Bartholin's gland, and thereby they will have very painful sexual intercourse, and that we call it as dyspareunia, right? Then, apart from glandular, you also have extraglandular. What is the most common extraglandular manifestation? That will be in the form of arthritis. The other extraglandular manifestations will be in the form of Raynaud's, vasculitis, and then the peripheral neuropathy. Apart from this, these patients will also develop type 1 renal tubular acidosis and as well as the interstitial lung disease. Very important question is that these individuals, they are at increased risk of development of lymphoma. What type of lymphoma is commonly observed in these patients? That is low-grade marginal B-cell lymphoma. Right, low-grade marginal B-cell lymphoma, and autoantibodies mainly anti-Rho and as well as the anti-La. So how will you diagnose this? So diagnosis is by your Schimmer's test that will demonstrate the tear secretion is reduced. Silometry that will demonstrate the salivary secretion is reduced, right? Where there will be salivary secretion less than 1.5 ml in 15 minutes, that is considered to be positive. And the confirmation can be done by the labial biopsy. Labial biopsy will show you that there is lymphocytic infiltration, which is most sensitive and as well as specific test for Sjogren's, right? And differential diagnosis, what is the other condition where you have the enlargement of the parotid gland is in sarcoidosis. And that syndrome is called uveo-parotid syndrome, or we call it as the Hereford syndrome. right? Or we call it as the Hereford syndrome. That is what you will observe in case of the sarcoidosis. Then how do you treat these patients with the Sjogren syndrome? The treatment in case of the Sjogren syndrome, symptomatic treatment, where you need to give the artificial tears for dry eyes and as well as lubricants. And for dry eyes, you need to give the cyclosporin as well, that can suppress the immune reactivity. And next is for xerostomia, where there is dry mouth. For dry mouth, you need to give pilocarpine or the cevimeline. And in systematic, because most common extraglandular manifestation is arthritis, for which you need to give NSAIDs for arthritis. Okay. And apart from NSAIDs, if the individual is not responding to NSAIDs, you need to give corticosteroids. And in severe cases, you need to give the immunosuppressants, that is rituximab should be given. And how is the overall prognosis, right? Quality of the life is very significantly affected. Why? Because there is dry eyes and dry mouth. But lifespan of the individual is usually normal, right? But when will you have the poor prognosis? If there is systemic involvement, then the individual will have poor prognosis. If there is systemic involvement, right? And if there is lymphoma involvement also, then the individual can have the poor prognosis. Okay. So this is about the story related to the Sjogren syndrome. So to quickly recap about the Sjogren's, autoimmune condition, dry eyes, dry mouth, ratio 9:1 between females and males, pathogenesis, lymphocytic infiltration, that is CD4 plus T lymphocytes into the salivary and lacrimal glands. Primary Sjogren's, isolated disorder. Secondary Sjogren's associated with other autoimmune disorder, right? And the key symptoms will be in the form of dry eyes and dry mouth. Extraglandular manifestation, the most common extraglandular manifestation will be in the form of arthritis and arthralgia, right? The autoantibodies that you observe is anti-Rho and anti-La. Diagnostic test, Schimmer's test for lacrimal secretion, cylometry for salivary secretion. Labial biopsy, highly sensitive and highly specific. Differential diagnosis, sarcoidosis. Treatment, symptomatic treatment. And along with that, you need to give cyclosporin for dry eyes, pilocarpine or cevimeline for xerostomia, and this for systemic involvement, NSAIDs for arthritis. In severe cases, rituximab. Quality of the life is compromised, but lifespan is normal. But the individual is said to have poor prognosis if there is systemic involvement. That is about the Sjogren's, right? Yeah. Yes, Sia Mirza. We are all doctors. We treat the patients. And by the way, who are you, Sia Mirza? By mistake, you have joined this channel. I am second year MBBS student from Pakistan. Sia Mirza, I think this particular session is very early for you to attend, right? You can save this and you can download this session. And by the time when you reach your fourth MBBS, then you can watch this session. I hope that will be useful at that time for you, right? But otherwise, this particular session is little early for you to get through with. Chalo. We'll move on to the next topic, that is the systemic sclerosis. Yes, answer this question. We have a 50-year female patient presenting into the rheumatology clinic with complaints of the skin changes and difficulty in opening the mouth. Upon examination, there is a tendon friction rub and she reports experiencing dry mouth. She also mentions a history of Raynaud's phenomena. Which subtype of systemic sclerosis is most likely be associated in this patient? Very good. So it is the limited cutaneous variety of the systemic sclerosis. Why? Because you have only the skin changes, right? And there is difficulty in opening the mouth. And the patient is having Raynaud's phenomena. That is also, again, the cutaneous manifestation. And there is tendon friction rub. That is because of the fibrosis of the skin within the fingers. That is also cutaneous manifestation. So visceral organ involvement is not there. Because the visceral organ involvement is not there, that is the reason why we consider that this particular patient is having a limited scleroderma, right? Now, shall we start with the systemic sclerosis? Right, let us start with. Now, if you take the definition of this particular scleroderma, right? Definition of the scleroderma. This is also a chronic disease. This is also a chronic disease where you have the abnormal accumulation of the fibrous tissue not only in the skin but also in the internal organs. But also in the internal organs, right? And this is also an autoimmune disease. That is the reason why it is more common in females rather than males. And apart from systemic sclerosis, or apart from the diffuse scleroderma and limited scleroderma, we have one more important form of scleroderma called localized scleroderma. And this localized scleroderma, the name which is given to this is morphia. Right? This is morphia, okay? And this is very common in children. This is very common in children. What is the problem here? The problem here is there is excessive fibrosis, which is triggered by abnormal immune response. What are the antibodies? The antibodies that you will have is the anti-nuclear antibody, anti-topoisomerase antibody, and anti-RNA polymerase 3. These three are the important antibodies, but out of which your anti-nuclear antibody, it is not specific because it is present in many other conditions. Now, what will be the first important manifestation that you will have in case of scleroderma? That will be in the form of Raynaud's phenomena. Then, what are the other skin manifestations in case of scleroderma? That will be in the form of increase in the thickness of the skin, that is sclerodactyly, right? Followed by that, you have leather-like skin, pitting scars, and tendon friction rubs. And you also have systemic involvement. That systemic involvement, gastrointestinal involvement can be there, where there is fibrosis of the lower esophageal sphincter, due to which there is GERD and as well as dysphagia. Lung involvement will be there. That will be in the form of interstitial lung disease. Kidney involvement will be there in the form of renal artery stenosis. Cardiac involvement will be there in the form of restrictive cardiomyopathy and dilated cardiomyopathy. So these are like multi-organ involvement that you will have in scleroderma. And as I have said we have two forms. One is limited scleroderma and diffuse scleroderma. Limited scleroderma, you need to remember this crest syndrome. Very, 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 very important. What is this crest syndrome? Where you have calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and as well as telangiectasia. This will be your limited scleroderma. Whereas in diffuse scleroderma, what did I tell you? Along with skin, multiple other organs are affected. What are the organs which are affected? GIT, lungs, kidney, heart. These are the organs which are affected in diffuse scleroderma. Right? ANA will be positive, but that is not specific. And you have two forms of scleroderma, limited and diffuse scleroderma. Now, where is it you will have this anti-topoisomerase antibody positive? Remember, in diffuse scleroderma, your anti-topoisomerase antibody will be positive. Where is it you will have anti-centromere antibody that will be positive? That will be positive in limited scleroderma, that is CREST syndrome. And because it's an inflammatory condition, the ESR will be elevated. Right? And how is that you will be able to evaluate the lung involvement, CT and as well as MRI? And what is that lung involvement? That will be in the form of interstitial lung disease. Now, because it is an interstitial lung disease, what does the pulmonary function test show? Pulmonary function test show that there is restrictive lung disease, where your FEV1 by FVC, FEV1 by FVC will be more than or equal to 70%. That is what you will see in case of pulmonary function test, right? And what will happen to the DLCO, diffusion capacity of the lung for carbon monoxide? It is reduced. Next, coming to complications. In case of scleroderma, the complications will be pulmonary hypertension. Why pulmonary hypertension? Because in scleroderma, you have interstitial lung disease, which is causing hypoxia. And hypoxia will cause pulmonary artery vasoconstriction, resulting in pulmonary hypertension. And this pulmonary hypertension is considered as the cause of death in patients with the scleroderma. And the other complications will be in the form of ILD. Why is that there will be renal crisis? Renal crisis will be there mainly whenever these patients develop renal artery stenosis. Done? Then gastrointestinal hypomotility will be there, and as well as the cardiac fibrosis also will be there in these patients. Then what are the other treatment options in these patients? The other treatment options are, because these patients are having the dysphagia, GERD is there. So you need to give the proton pump inhibitors. That is mainly for GERD. These patients, if they have arthritis, you need to give NSAIDs. And as I have said you, like ILD will be there. And for that particular ILD, the drugs that you should give is mycophenolate mofetil, cyclophosphamide, or nintedanib. And the cause of death is pulmonary arterial hypertension. So how will you reduce the pulmonary artery pressure? By giving PA lowering pressure drugs. That is sildenafil, which is a phosphodiesterase inhibitor, bosentan, and as well as the prostacyclin. Next step is saying you about the renal crisis. Why is that due to renal artery stenosis? Whenever there is renal artery stenosis, there is activation of RAS. So for that, what we should give? You should give the ACE inhibitors. And overall, how will be the prognosis in these individuals? 9-year survival rate is around 40%. But in which group of scleroderma, you will have poor prognosis. So please remember, mainly whenever there is diffuse scleroderma, then they are considered to be having poor prognosis. And the other poor prognostic features are older age and as well as lung involvement. Because whenever there is lung involvement, there is development of pulmonary arterial hypertension, and that can cause the death in the individual. Okay, so this is about the story related to the scleroderma. Right. Review on infectious disease. Amzad, no. Because infectious diseases that will be done in your microbiology, right? So I will not do infectious disease here. Chalo. Let me quickly recap about the scleroderma. Chronic disease, abnormal fibrous tissue accumulation, autoimmune condition, so more common in women rather than men, right? You have an trigger by the abnormal immune response. The antibodies will be ANA, anti-topoisomerase, and anti-RNase polymerase 3. Raynaud's phenomena is the first manifestation. Skin sclerodactyly and pitting scars. Multiple organ involvement, GIT in the form of GERD, lung involvement in the form of ILD, kidney in the form of renal artery stenosis, and heart in the form of cardiomyopathies. Right? Two forms, limited and diffuse scleroderma. Right? And in diffuse scleroderma, anti-topoisomerase. Limited scleroderma, anti-centromere antibody. Pulmonary function test will show you that there is restrictive lung disease, where FEV1 by FVC will be more than or equal to 70%. Cause of death, pulmonary hypertension. Treatment, you need to give proton pump inhibitors for GERD. Lung involvement, you need to give mycophenolate mofetil. Right? And pulmonary arterial hypertension, you need to give sildenafil and as well as bosentan. Renal crisis, you need to give ACE inhibitors. Actually, drug of choice will be steroids. Why is that drug of choice is considered steroids? Because in the pathogenesis, what did we discuss? It is triggered by abnormal immune response. So you need to suppress the immune reactivity. So for that, you need to give the steroids. Okay. And how will be the prognosis? Poor prognosis, mainly in case of diffuse scleroderma. Done. So that is about the story related to scleroderma. Okay. Next topic for the discussion, that is Behcet's. Next topic for the discussion will be Behcet's. Yes. All of you, are you ready with the Behcet's? Shall we start with the Behcet's? Chalo, we'll start with the Behcet's. So Behcet's, this is also a multi-system inflammatory disorder. Multi-system inflammatory disorder. What is the pathognomic feature of the Behcet's? That will be ulcers. Where will be these ulcers? Oral ulcers and genital ulcers. And apart from these ulcers, you have the skin lesions and then ocular involvement in the form of anterior and posterior uveitis, and there will be also vasculitis. And what is the age group at which you see Behcet's commonly? Young children. And in which countries this is very common? It is common in the ancient Silk Road regions. That is Turkey. Turkey is most common. What is the HLA association? B51 is the HLA association, right? And what is the manifestations? The key symptoms are oral ulcers, which are very painful. Aphthous ulcers in the oral cavity. Genital ulcers, they scar. Oral ulcers, there is no scar formation. Genital ulcers, there is scar formation. And both of them, they are very painful. And skin manifestation will be in the form of erythema nodosum-like lesions. Ocular involvement will be in the form of anterior and as well as the posterior uveitis. And it is a multi-system involvement, right? CNS involvement can be there in the form of sterile meningitis and cranial nerve palsy. Gastrointestinal involvement can be there in the form of ulcers over the ileum and as well as the cecum. And it will also cause vasculitis, that is mainly pulmonary artery aneurysms. There can be deep vein thrombosis as well. Arthritis will be there, that is in the form of non-deforming arthritis. Okay, so this will be the other manifestations. So what are the complications? That is pulmonary artery aneurysm. And whenever this pulmonary artery aneurysm rupture, these patients will develop a life-threatening hemorrhage. These patients will develop a life-threatening hemorrhage. What is the diagnostic criteria? Diagnostic criteria is recurrent, painful oral and the genital ulcers. Skin manifestation will be in the form of erythema nodosum. And how will you diagnose? You need to do a skin hyperreactivity test. And that skin hyperreactivity test is the pathogenesis test that will be positive. But as such, is there any specific diagnostic test? No. The HLA-B51 will be positive, and acute phase reactants like ESR and CRP is being elevated. So how do you treat these patients? The treatment is by, like the mucocutaneous lesions have to be treated by the colchicine, topical steroids, and apremilast. And if the disease is like severe disease, you need to give prednisolone and azathioprine. And if there is the CNS or ocular involvement, you need to give the infliximab, cyclosporin, or cyclophosphamide, right? So these will be the treatment in case of Behcet's. And how is the life expectancy? Normal life expectancy. But what would be the reason for the morbidity? The reason for morbidity may be mainly the blindness, because there is anterior and as well as posterior uveitis in this patient. So this is about the Behcet's. So Behcet's is what? Multi-system involvement, right? And commonly seen in young adults, commonly observed in Turkey. HLA B51 positive. The pathognomic manifestation, oral ulcers, that too painful ulcers in the oral cavity, and they don't scar. And that too a recurrent oral aphthous ulceration. CNS manifestation, sterile meningitis. Vasculitis, pulmonary artery aneurysm. Complications, this pulmonary artery aneurysm can rupture, causing life-threatening hemorrhage, right? And there is no specific diagnostic test. Mainly the HLA-B51 will be positive and the pathogenesis test will be positive. The treatment is you need to give colchicine and as well as topical corticosteroids. And in severe cases, you need to give the infliximab. Severe cases, prednisolone. CNS or ocular manifestations, you need to give infliximab, right? So that is about the treatment. Yeah, these are all previous year topics. These are all previous year topics, definitely. And yeah, DVT may anticoagulation. Yeah, if there is development of DVT, definitely we give anticoagulation. Definitely we give anticoagulation. Okay, chalo. Shall we start with the next topic, that is gout or the gouty arthritis? Gout or gouty arthritis. Answer this question. Shinavas, yes. Negatively birefringent crystals. Monosodium urate crystals. Shinavas, where do you have positively birefringent crystals? Where is that you'll have positively birefringent crystals? Positively birefringent crystals are observed in pseudogout. In pseudogout, you will have positively birefringent crystals. And the name of the crystals are the CPPD crystals. CPPD crystals. That is calcium pyrophosphate crystals. Calcium pyrophosphate dehydrogenase crystals. Okay. Right. So the most initial treatment that you have to give in case of acute gout will be the ice pack application. That will be ice pack application. Right. Yeah, yes. In pseudogout, it is the knee joint, but in case of gout, it is the first metatarsophalangeal joint. Okay, right. Let us start with a quick discussion related to the gout. So gout, if you take, it is the disorder of the purine metabolism. It is a disorder of the purine metabolism, and that will lead to increased production of the uric acid or maybe decreased excretion of the uric acid. So basically, what is the problem here? The problem here is the levels of the uric acid is increased, right? Why this particular levels of the uric acid is increased? Either because of the increased, yes. So either because of the increased uric acid synthesis or decreased uric acid excretion. Right. And the joint which is commonly affected is first MTP, where you have the accumulation of the monosodium urate crystals within the joint, right? And it is more common in men rather than women. More common in men rather than women, right? And pathophysiology, if you observe, the hyperuricemia, whichever is there, the uric acid which is increased, that will go and accumulate within the joints. There will be supersaturation of the synovial fluid with the urate. And that particular urate is converted into crystals. And that too, it will be a monosodium urate, negatively birefringent, needle-shaped crystals. The first joint which is affected is the MTP, followed by that midfoot, ankle and knee. Risk factors, very, very important risk factors. Alcohol consumption, uric acid spikes up. High purine diet, because it's a disorder of the purine metabolism. So the uric acid increases. Thiazides and loop diuretics, uric acid increases. Low dose salicylates, they will also increase the uric acid. So what is the diagnosis? Hyperuricemia. But this hyperuricemia, we cannot consider it as a definitive diagnostic test because in some cases of acute attacks, the uric acid may be normal. In some cases of the acute attacks, the uric acid can be normal, right? And what is a confirmatory test? The confirmatory test is the synovial fluid analysis, where you have negatively birefringent, needle-shaped monosodium urate crystals. What will be the radiological imaging finding? Radiological imaging finding is there will be punched out erosions, and that we describe it as the rat bite lesions. What is the treatment that you will give? In acute attack, you need to give NSAIDs or aspirin. I'm sorry, we don't give aspirin. I'm very sorry. We give indomethacin, colchicine, and glucocorticoids in case of severe conditions. And in chronic gout, you need to give xanthine oxidase inhibitors, that is allopurinol and febuxostat. Or you have a uricosuric agent, that is probenecid. Uricosuric agent, that is probenecid. But please remember these chronic drugs, that is your allopurinol and febuxostat, they are not useful in acute attacks. And what is a complication? This particular uric acid can accumulate within the soft tissue in the form of the tophi. And it can accumulate within the kidney in the form of gout or gouty nephropathy. And the uric acid can accumulate in the form of the renal stones. So these are the complications. Okay. And coming to the pseudogout. Pseudogout actually mimics the gout, but the joint which is commonly affected is knee joint. And the crystals that are being accumulated is calcium pyrophosphate dehydrogenase crystals. How will you diagnose? Same, joint aspiration, but these are positively birefringent. Then how do you treat these patients? You need to give NSAIDs. You need to give NSAIDs, okay, in case of pseudogout. So this is about your gout and as well as the pseudogout, okay. So, right. So for those newcomers who are joining this particular session, let me just tell you again. The PDF of this channel is present on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, and you can download this PDF from this Telegram channel. Done? Okay. Now, let us take up the next topic, that is vasculitis. Right. So if you take this, the vasculitis, what exactly is the problem here? Here you have the inflammation and destruction of the blood vessels. And how do you classify this vasculitis? We classify the vasculitis depending upon the vessels which are being affected. Like you have large vessel vasculitis, medium vessel vasculitis, and as well as now we have large vessel vasculitis, medium vessel vasculitis, and as well as the small vessel vasculitis. Large vessel vasculitis, it mainly affects the aorta. And what are the examples of large vessel vasculitis? That is Takayasu and giant cell arthritis. And what are the examples of medium vessel vasculitis? That is polyarthritis nodosa, Kawasaki disease, and as well as the Buerger's disease, which is nothing but thromboangiitis obliterans. Then small vessel vasculitis. What is the examples of the small vessel vasculitis? That includes Wegener's, Church-Strauss syndrome, and as well as the Henon-Schollen's purpura. Right? These are the examples of the small vessel vasculitis. And one more important example of the small vessel vasculitis is what? That is microscopic polyangiitis. Right? Microscopic polyangiitis. And all these vasculitis, let me tell you, they are the disorders of multiple system involvement. So multi-organ involvement will be there in these patients with the vasculitis. Out of all these, let me just tell you some important questions. The important questions are related to ANCA. C ANCA, your Wegener's will be positive. P ANCA, that will be positive in case of the microscopic polyangiitis and as well as the Church-Strauss syndrome. And in majority of the conditions, because the inflammation is the key point, the treatment drug of choice will be prednisolone. And in severe disease, we give cyclophosphamide and rituximab. And in specific conditions like Kawasaki, you need to give intravenous immunoglobulin and aspirin. And if there is renal involvement, you need to give mycophenolate mofetil. Okay. Now we'll try to take up the individual conditions. We have a 10-year-old child presents with red raised rash on the buttocks and legs. The mother reports that the child also has the joint pains, abdominal pain, fresh blood in the stool yesterday. Laboratory investigation reveal elevated levels of the IgA. What is the most likely diagnosis? Yes. Anyone? Right, good. So it is a case of the Henon-Schollen's purpura. So Henoch-Schönlein's purpura, the another name for this is, it is the IgA vasculitis. The another name for this is the IgA vasculitis, right? Which is a complex immune-mediated vasculitis. It's a complex immune-mediated vasculitis, and it's a small vessel vasculitis. Okay. And in case of the Henoch-Schönlein's purpura, you should have a tetrad. What is that particular tetrad? The tetrad that should be there is H, S, and P. These P I will write 2 times. What is H? H stands for the hematuria. The H stands for the hematuria. S stands for the skin abnormality. That will be in the form of palpable purpura. P stands for pain in the abdomen, right? Pain in the abdomen. And another P stands for pain in the joints. Okay. Now, in the diagnostic criteria, 4 important criteria is there. Out of 4, at least 2 should be there. Number 1, purpura, palpable purpura. Number 2, the abdominal bowel angina, where you have the GIT involvement. Okay. Then next important is diagnostic picture will be biopsy, right? Where the biopsy will show you that there is IgA vasculitis. Right, where you'll have the IgA vasculitis. Okay, that will be the biopsy picture, right? And what is the age group at which you'll be seeing this Henoch-Schönlein's purpura? Less than 20 years. So out of 4, minimum 2 should be there for diagnosis of this IgA vasculitis. And remember, your IgA nephropathy is different. IgA nephropathy, that will be your Berger's disease, where you have recurrent hematuria. Whereas IgA vasculitis is different, which is the Henoch-Schönlein's purpura, right? So if you take this Henoch-Schönlein's purpura, this is the summary. So skin involvement will be in the form of palpable purpura. Gastrointestinal involvement will be in the form of abdominal pain and melena. Kidney involvement will be in the form of the hematuria and proteinuria due to glomerulonephritis. Joint involvement will be in the form of arthritis. And when you do a skin biopsy is considered as the investigation of choice. Right? And what is that you will be observing in the skin biopsy? You will notice that there is presence of IgA and as well as C3, right? And in severe cases, the renal biopsy may be helpful. And what will be the clinical features? Palpable purpura, abdominal pain, and as well as the hematuria, right? Then how do you treat these patients? Treatment completely depends upon the severity of the disease. If the individual is having mild disease, supportive care, like where you will give hydration, NSAIDs for joint pain. For severe disease, you need to give prednisolone. For severe disease, you need to give prednisolone, that is corticosteroids have to be given, right? But if the individual is having a rapid progression, then rituximab or plasma exchange has to be done. And how will be the prognosis? It is generally self-limited in children, right? But adults may develop the chronic renal disease. Adults may develop chronic renal disease. This is about your Henoch-Schönlein's purpura, which is nothing but your IgA vasculitis. And another important vasculitis is Kawasaki, which is a medium vessel vasculitis. Yeah, yes, Amjad. How do I know that it is a severe disease? Yes, Amjad, if suppose, where is that? Yeah, if there is the involvement of all the 4, that means there is palpable purpura, there is also arthritis, there is also hematuria, right? And there is also abdominal pain. When all these 4 are there, then you should consider it as severe disease. Okay. Yes, Amjad, is that clear, Amjad? Right. Now, which of the following is the most appropriate treatment for Kawasaki? Yes, the most appropriate treatment for Kawasaki is what? That is intravenous immunoglobulin. Let me take up the discussion of the medium vessel vasculitis, that is Kawasaki. So Kawasaki, it predominantly affects the children. It predominantly affects the children. Okay. And in these individuals, what is the characteristic finding? Along with fever, these patients will develop mucocutaneous lymph node syndrome. Mucocutaneous lymph node syndrome. 80% of the cases, it occurs in children under 5 years of age. 80% of cases, it occurs in children under the 5 years of age. And it is more common in boys rather than girls, right? And in acute phase, what is the manifestation? Fever. And this particular fever should be there for more than 5 days. That's a very, very important manifestation in Kawasaki. And I said you it is mucocutaneous lymph node syndrome. You will be having, or the patient will be having, the cervical lymphadenopathy, and the tongue will be like strawberry tongue. What will be the vessel that is commonly affected? Coronary artery. And that coronary artery involvement will be in the form of the coronary artery aneurysm. And other cardiac manifestations will be myocarditis and pericarditis, right? And what will be the laboratory manifestations? Because it's an inflammatory condition, the ESR and CRP is being elevated. ESR and CRP is being elevated. And the other features that you'll have is neutrophilia, thrombocytosis will be there after 1 week, hypoalbuminemia, and echocardiography is done in order to look for the coronary artery abnormality. And then how do you treat? So treatment completely depends upon whether the patient is presenting in acute stage or whether the patient is requiring long-term treatment. In acute stage, the intravenous immunoglobulin and aspirin should be given. Then what is that which is required as a long-term? Aspirin should be given in order to prevent the coronary artery thrombosis. And if at all, if there is coronary artery thrombosis, you need to give fibrinolytic agent. Then how is the prognosis in this individual? For example, if you are starting the treatment early, the prognosis is good. If you are starting the treatment early, the prognosis is good. But in untreated cases, they have significant risk of the coronary artery aneurysm. In untreated cases, there is significant risk of the coronary artery aneurysm, and there will be long-term cardiac complication. So this is about your Kawasaki. Done? Okay. Now, yeah, Amzad, how can I give aspirin if the patient has aneurysmal risk for the bleed? See, in case of the aneurysm, if it is there, it is not that you cannot give the aspirin. Why? Because if you don't give aspirin, what will happen? Whenever there is coronary artery aneurysm, there can be stasis of the blood. Right? There is slow movement of the blood. That is equivalent to stasis. This can precipitate the thrombus formation. Right? And once there is a thrombus, the individual will develop MI. So to prevent this thrombus, I need to give a low dose aspirin. To prevent this, you need to give low dose aspirin. I'm not saying like high dose aspirin that we give in case of acute rheumatic fever. Low dose aspirin has to be given. Okay. Right. Now coming to the large vessel vasculitis, and this large vessel vasculitis is Takayasu. Takayasu. Okay. So Takayasu, which is a large vessel vasculitis, it is very common in individuals of age less than 50 years. Right, less than 50 years, right? And in these patients with Takayasu, the common vessel that is affected is left subclavian artery. That is the reason why the blood supply to the radial artery will get compromised, and the individual will not, you will not be able to feel the pulse. That is why it's called pulseless disease. And what are the symptoms in these individuals with Takayasu? Fatigue, visual disturbances, and hypertension. This hypertension, that is mainly due to renal artery involvement in patients with Takayasu. Then how will you diagnose? The investigation of choice is MRI of the aorta. MRI of the aorta, MR aortography. And it's an inflammatory disorder. ESR will be elevated. And it's an inflammatory disorder. You need to give corticosteroids. And if there is multiple organ involvement and refractory scenario, biologicals should be given. That is the methotrexate. So that is about your Takayasu, which is nothing but pulseless disease, or it is also called aortoarthritis. Right? It is also called the aortoarthritis. Right? Yes, Harmandeep. Hi. Right? And yes, Harmandeep, this particular session will be useful even for the MDS entrance exam as well. This will be a quick revision. So even for you also, this particular sessions will be useful. Right? Now, the next important form of large vessel vasculitis will be the temporal arthritis. Temporal arthritis, it is very common in age group more than 50 years. And what is the most common vessel that is affected? The most common vessel affected is the temporal artery. That is the reason why it is called temporal arthritis. That is the reason why it is called temporal arthritis. Okay. And the temporal artery will be inflamed and it is very tender to touch. And these patients will have the headache. And due to the involvement of the ophthalmic artery, these patients will have the visual loss. And due to the involvement of the temporal artery, the blood supply to the muscles of the mastication will be compromised. And thereby these patients will have the jaw claudication. And how will you confirm the diagnosis? By doing the temporal artery biopsy. Temporal artery biopsy, when you do, you will notice that there is granulomatous inflammation. You will notice that there is granulomatous inflammation. And ESR is being elevated, that will be more than 50 millimeters per hour. And it's an inflammatory disorder, so you need to give immunosuppressant, corticosteroid. Refractory cases or in severe cases, you need to give the tocilizumab. You need to give tocilizumab. Okay. So these patients will have the important symptomatology in the form of headache. Then next, let me take up another important medium vessel vasculitis, that is polyarthritis nodosa. So polyarthritis nodosa, let me tell you, it affects all the organs. But the organ that is spared in polyarthritis nodosa is lung. If lung involvement is there in the clinical scenario, it is not polyarthritis nodosa. And what are the symptoms then? Hypertension and mononeuritis multiplex. How will you diagnose? By doing biopsy. Biopsy will show you that is necrotizing arthritis. How do you treat polyarthritis nodosa? It's an inflammatory condition, immune-mediated disorder. Corticosteroids should be given, and as well as the cyclophosphamide, right? Cyclophosphamide, okay? And another important vasculitis is small vessel vasculitis, that is Wegener's and Churg-Strauss. Another name for Wegener's is what? Granulomatosis with polyangiitis. And in Wegener's, you have a triad. What is a triad, right? So you have a triad. Okay. Yes, Almarva, right? So I said you, this PDF is available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. And you can download this PDF from my Telegram channel. Okay. Right. Chalo. So granulomatosis with polyangiitis, that is Wegener's, where you have a triad, where you have the upper respiratory tract involvement, lower respiratory tract involvement, and you also have the kidney involvement in the form of the glomerulonephritis. And symptoms will be in the form of like sinusitis, hematuria, and saddle nose deformity. Why is it they have that saddle nose deformity? Because there is collapse of the nasal cartilage. That is the reason why you'll have saddle nose deformity. What is the investigation of choice? The investigation of choice will be Sianka. And how do you treat? The immunosuppressants like rituximab and cyclophosphamide will be given, right? Then the next important is the eosinophilic granulomatosis with polyangiitis, which is nothing but the Churg-Strauss syndrome. So Churg-Strauss syndrome, the classical picture will be asthma. In any form of vasculitis, if asthma is there, that will be Churg-Strauss. And along with that, these patients will have eosinophilia. And how will you diagnose? Along with elevated P-ANCA, you will have increase in eosinophil levels, because the P-ANCA is also elevated in microscopic polyangiitis as well. Then how do you treat this eosinophilic granulomatosis with polyangiitis? Corticosteroids. In severe cases, the azathioprine and as well as the mepolizumab should be given, right? Mepolizumab and azathioprine should be given. Okay, so this is about granulomatosis with polyangiitis. And last important form of the microscopic polyangiitis, last important form of small vessel vasculitis is microscopic polyangiitis, where you have the involvement of venules, capillaries, and as well as arterioles. So what will be the problem? There can be rupture of the capillaries within the lung resulting in pulmonary hemorrhage, and there can be rupture of the glomerular capillaries that will be resulting in glomerulonephritis. And in microscopic polyangiitis, you will have P-ANCA. And P-ANCA is not only present in microscopic polyangiitis, even in Churg-Strauss syndrome, you will have the P-ANCA being present. And how will you diagnose? Biopsy will also show you that there is necrotizing vasculitis. How do you treat? Rituximab and as well as the cyclophosphamide should be given. Rituximab and cyclophosphamide should be given, right? So this is about the story related to the vasculitis. So all the vasculitis in nutshell, the entire vasculitis in nutshell. Okay, then coming to the next topic, that is sarcoidosis. Yeah, answer. Right. A 35-year-old male presents with 2 months history of persistent dry cough, fatigue, and shortness of breath. Biopsy shows presence of naked granulomas, HRCT, chest gallium scan, first-line treatment. Yeah, yes, Prateek, thank you very much. Yeah, Antique, thank you very much. Shanavas, thank you very much. Adhikari, thank you very much. Right? The appreciations, whatever you give, is the one which is a key motivator for the educator, right? And you try to motivate a lot, the educator will try to give a lot. Chalo. So what is a diagnosis here? Diagnosis here is, so in the gallium scan, what is that you are having is panda sign. You are having a panda sign. This is number one. Then in the CT, what is that you are observing is, in the CT, you are observing the galaxy scan. Right? In the CT, you are observing galaxy sign. Okay. So CT showing galaxy sign and panda sign in the gallium, and the presence of the naked granulomas. Presence of non-caseating. Naked granulomas means non-caseating granulomas. So galaxy sign, panda sign, naked granulomas. All these, they point towards sarcoidosis. All these, they point towards the sarcoidosis. So what is the first line treatment in sarcoidosis? Steroids. Steroids is what we'll give, right? Now, that is the first line treatment. Agar, if the patient is developing Cushing syndrome due to steroids, what is a steroid sparing agent? The steroid sparing agent will be the hydroxychloroquine. Hydroxychloroquine will be steroid sparing agent, right? When will you give methotrexate? Methotrexate is another steroid sparing agent, right? And what is the third steroid sparing agent? Azathioprine. When will you give like infliximab? You will give infliximab whenever there is severe or refractory cases. Severe or refractory cases, you should give infliximab, right? So this is about the treatment in sarcoidosis. Let me just quickly recap the sarcoidosis. Okay. What is this sarcoidosis? This is also a chronic inflammatory disease where you have the presence of non-caseating granuloma in the lungs and other organs. But the common organ which is affected is lung. Along with lung involvement, you have the bilateral hilar lymphadenopathy, which is the hallmark feature in patients with sarcoidosis, right? And the age group at which you see this sarcoidosis, 20 to 40 years. What is the pathogenesis? That is, you have a trigger. What is the trigger? The trigger is by the Propionibacterium acne, then Mycobacterium tuberculosis. These are the triggers, right? And this particular triggers will trigger the immune system and there will be immune reactivity. And in these individuals, you have inclusion bodies. What are the inclusion bodies? Sharpen bodies, asteroid bodies, and we have one more, residual bodies. One more, residual bodies. So these are the inclusion bodies, Sharpen bodies, asteroid bodies, and then the residual bodies. Most common organ affected is lung. Lymph node involvement, bilateral hilar lymphadenopathy. Skin involvement will be there in the form of erythema nodosum and lupus pernio. And cardiac involvement will be there in the form of restrictive cardiomyopathy, and that is a cause of death in these individuals. So lung involvement, that will be in the form of interstitial lung disease. And due to this interstitial lung disease, they'll be having dry cough and dyspnea. Skin involvement in the form of this erythema nodosum and lupus pernio. Lymph node involvement, bilateral hilar lymphadenopathy. CNS involvement in the form of lymphocytic meningitis and optic neuritis. Ocular involvement will be in the form of uveitis and as well as the Zika syndrome, right? So this will be clinical features. And whenever you take the chest X-ray, apart from bilateral hilar lymphadenopathy, you have totally 3 types of chest X-rays in sarcoidosis: type 1, type 2, and type 3. Type 1, there will be bilateral hilar lymphadenopathy, but parenchymal involvement will not be there. Type 2, bilateral hilar lymphadenopathy will be there. Along with that, parenchymal involvement also will be there. Type 3, you will have diffuse parenchymal changes, but hilar lymphadenopathy will not be there. Hilar lymphadenopathy will not be there. Just give me 1 minute. Chalo. So these are the 3 important radiological patterns. And how will you diagnose? Because it's an inflammatory condition, ESR will be elevated, right? And the hypercalcemia will be there. Why? Because this non-caseating granuloma will be producing vitamin D. And there will be elevated ACE levels from this non-caseating granuloma. And if you take CD4 to CD8 ratio, it will be like 10:1. What is a confirmatory diagnosis? Confirmation is by your biopsy. Biopsy will show you that there is non-caseating granuloma, right? And Queen-Silsbach test we are not doing now. It was a good olden test, right? In the olden days, we were doing this Queen-Silsbach test. What are the special sign? That is lambda sign and as well as panda sign. This lambda sign and panda sign, that is by gallium-68 uptake studies. That is lambda and as well as panda, right? And because it's an inflammatory condition, so what is that you need to do? You need to give the corticosteroids. Refractory cases, what is that you need to give? Methotrexate, azathioprine, and infliximab, right? And whenever there is CNS involvement, that is when you need to give this methotrexate, azathioprine, and infliximab. Whenever there is CNS involvement, right? And what are the good prognostic signs? Okay, so if there is hilar lymphadenopathy or erythema nodosum, it's a good prognosis. But if there is progressive lung fibrosis, poor prognosis. And what will be the long-term complication? Restrictive cardiomyopathy, that will be causing arrhythmias and sudden cardiac death. Okay, so this will be the topics in connective tissue disorders, right? So with this, I'm done with the connective tissue disorders, and as well as what was the other topic that we have done? The hepatology. Okay, so I will stop for now. Right, I'm completely tired because continuously talking for almost 2 to 2.5 hours, right? So there is a complete fatigue in my voice. I'll just wind up the session right now. Tomorrow again at 7:30 we will start. So tomorrow we will start with the neurology first, because many of the students are asking the neurology. So neurology also I have made it in the form of tables. So please follow me tomorrow at 7:30 on the same YouTube channel. Definitely we will do neurology and as well as the pulmonology and some more topics if I have the the energy tomorrow once I finish the neurology and the pulmonology, right? But take it from me, granted, all the topics I will do, right? But I may be doing it in the split manner. All the topics, all the subtopics I will do, okay? And you just listen to these particular sessions, 70 to 80% of questions in general medicine you will cover by these topics, okay? Chalo. With this, we'll wind up this session. Thank you very much. See you tomorrow at 7:30.